in a superior choroidal tumor. I'm not going to cover the rest just for time reasons. So lacrimal gland biopsy. So this is a mass, we don't know what it is, infiltrative sclerus. I mark the tumor or the lesion, and then I do a upper lid skin crease incision. We heard from Santosh yesterday, if you think it's malignant, I prefer doing a subbrow incision because then that can be included in the radiation zone. If I think this is inflammatory or non-cancerous, then usually I do an upper lid skin crease incision. So I could show videos, but we'll skip through it today if that's okay. Upper lid skin crease is for, this is Bhupi Patel who discovered this approach. Most people were doing transconjunctival, detaching the medial rectus going down medially, but this approach is the shortest distance to the optic nerve, and that's why when children get pencil injury in the superior medial fornix, they lose vision because it transects the nerve. So this is the shortest distance to reach the optic nerve, end on view, and you can do the optic nerve sheath penetration through this approach. I mean, it's just a quick video to say, you can see the beautiful axis, you straight gate, make a slice on the optic nerve, and then get the CSF leak coming out straight away, and then you can extend the wound with Kelly's punches to make a decent sized window. There you go. So just a nice window to expose, the optic nerve. So this is a good approach to it. Yeah, it gives excellent results. So this is a young lad who I was a bit worried about. He's got a medial rectus mass. It turns out that did a retrocurricular approach. So I mean, I think it's a retrocurricular. Some people call it a transcurricular. I actually go between the caruncle and the plica because I find that gives me a nice plane to reach the medial part of the orbit. Just a quick video if I can. Local anesthetic in that area to reach the medial portion, 45 degrees angle in your Stevens, you're back at the posterior lacrimal crest. Once you that's the 45 degrees, 30 to 45 degrees, and just straight onto the periosteum. You go down, open the periosteum, and then where you want, open the periosteum just where you want to take the biopsy from. So it turned out quite an unusual case of vedolizumab related myositis, which improved. Orbital apex lesions, again, for this I prefer, I know you can go transnasally, I prefer the retrocurricular approach because that's what I've been taught to do, and I extend it onto the lower lid quite nicely. I can extend these incisions to the, retrocurricularly to the lower lid if I want to, or upper lid if I want to give me the access I need. I get straight onto the medial wall, identify inferior and posterior ethmoidals, and then 5 millimeters behind the posterior ethmoid is my optic canal, so I can then reorient myself on the scan where the tumor is. And I know we talked about cryo yesterday. I prefer using a cryo, but I use the cryo the opposite side, so not the end. You don't want to pull too much because you can rupture tissues. I go beyond the tumor, use the cryo and roll it out, so the movement is slightly different and doesn't cause as much trauma. So thankfully this patient didn't get any nerve palsies despite me using my maneuver, but gives good results. Transcaruncular approach, conjunctival approach, you can actually go to the inferior orbit quite nicely. So this is a chappie who's got a big orbital, inferior orbital pus mass, pus coming from the maxillary sinus. So I put a lid margin incision fibroproline. I use a mid incision halfway between tarsus and fornix to make my cut and dissect down to the orbital rim. You just open the periosteum and straight away the pus just flows out, suction. If you think there's an intraconal or extra periosteal abscess as well, you can open the periosteum and clean up in that area quite nicely. And this axis really gives you a good view of the inferior floor. Again, you can do a swing outside, or you can retrocurricularly increase, so you can move around depending on how much access you need. So I showed you a couple of these images earlier. You can use it to put plates in depending on where the accesses you need to reach. Lateral orbitotomy, this is my favorite approach for an intraconal cavitous hemangioma. Big bold incision, you can do an S-shaped incision. And in the cadaveric skills, we learned how to take the lateral wall off, so I think most of you were here. So it's quite a neat way of getting into the deep part of the lateral orbit. You then isolate the lateral rectus muscle on slings, and you can then, again with cryo, the rolling technique, just bring out the hemangium out nicely. We've experienced, mid-face plating. They're quite nice C-shaped plates, one on each side of the defects. Often all that's required. And yeah, it's one of the most satisfying surgeries as an orbital surgeon. This chap has a superior orbital mass, which I need to biopsy. It's quite tricky really going through the upper lid skin crease because you've got levator, you don't want to damage it. What do you do? So, I mean, using my experience in doing transconjunctival work for ruthenium plaques and proton beam, came up with this W incision. It's very simple really. You do, limbal based peritomy, and then you make an incision parallel to the lacrimal gland ductus. You can actually come from here, so bring this here, and do a lateral canthotomy, upper cantholysis. And that literally opens the lid like a book. I find that quite useful really. I use it more and more often. So I'll spend a quick minute on this one. So that's your marking done. And then really upper lid canthotomy. That you can just see how the lid sort of opens up and you get access. You can hook the superior rectus. You can actually hook the superior oblique this way. Just straight back onto nearly as far deep as you need. Really helps me put my plaques, put markers on, taking a small, I don't do this. I did my blade incision towards the globe, used the blade away from the globe, but in the heat of the moment, I just wanted a small biopsy, a decent biopsy, so I've done that. But really, you can go back as far as you can with with this W incision, and it closes quite nicely. You close the lateral, the conjunctiva and the lateral canthus quite neatly. Just allows you to get access medially and laterally in the superior orbit, which previously I was struggling with. So approaches, lots of different approaches. Make a plan. My first thing I would say is decide what you want. If you made a plan, often you have a higher chance of getting things right. Last slide to say thank you for amazing speakers. I came here to talk, but I think I learned more from you guys. So thank you, Ganga. Thank you, everyone, and thank you for listening.
So it's my pleasure now to introduce Dr. Morgan Yang.